Hi, everyone. Want to welcome you to another edition of VBC One Take. And what I really like about doing this podcast is it gives us an opportunity to showcase other innovators and thinkers and thought leaders in the space so that you, as the value-based care community, get to learn more about who's out there and what they're doing. And this episode is not any different. I'm really excited to bring to you someone who I really enjoyed getting to know and learn from, and think all of you will as well. I would like to introduce to you Kanar Kokoy, who is CEO and founder of Chirok Health. Welcome and thanks for being with us today, Kanar.
Thank you, Shannon. I appreciate it.
I would love to start off before we get into talking about industry trends and things that are going on around the industry. I would love for you to talk a little bit about who you are, who Chirok Health is, so our audience gets to know a little bit more about you before we dive into our conversation.
Again, thank you so much for having me on your podcast, Shannon. Kanar Kokoy, founder and CEO of Chirok Health. Chirok is a clinical documentation, integrity, risk adjustment, and revenue cycles management company. The way that we do business is very simple. We want to make sure that the clinical picture is accurate, complete, and defensible before it touches a claim. Actually, that is why I named the company Chirok. I'm Kurdish by background. The word Chirok means story. And I do believe that whether we are a patient, an employee, or a colleague or a friend, every individual has a story. And in our industry, that story is told through the documentation in the healthcare industry. And once that story has been transcribed or dictated through the documentation, then it also gets translated into codable diagnosis or procedure codes. And we want to make sure that story truly reflects what has been rendered. What drove me to build Chirok was a gap that I kept seeing in the industry, and that was where many organizations were investing heavily in coding and documentation. But oftentimes I saw that the people that were doing the work were not really equipped to understand the clinical content behind the work. And this is one of the reasons when I established Chirok, over 90% of our employees are clinicians. And the reason for this was that not only they have the coding or the billing or the CDI background, but I wanted them to make sure that there's a correlation of that clinical gap as well, and that they have a good understanding of what is truly happening between the clinicians or clinical staff and the patient. Chirok, we serve many large integrated health systems, academic medical centers, ACOs, MS, and as well as payers. And we do work across value-based and fee-for-service environment. So we have many complementary services that we've created that it is a hybrid model for many of our customers where the need for value-based as well as fee-for-service is there. And today, I'm really looking forward to getting into some of the conversations that matters the most right now, whether it's on the AI governance or payer-driven down coding or any of the future risk adjustment rules and policies, and what it truly means to build a foundation CDI program that holds up a lot of these scrutiny and it is defensible. That's the most important, which we continuously have to echo to all healthcare professionals, is that we want to make sure that the revenue being generated is defensible through any claims that is being reported.
100%. And such a timely topic. And we know that with a lot of the recent rulings, there's been a lot of discussion around making sure that what we're documenting is accurate. And I think that there's opportunities both ways, both overstating as well as understating. And I definitely know that there has been interest in the community for several years now around using clinicians. So I definitely think that makes you quite special in being able to
Thank you.
provide a service. Kanar, as I shared, there's been a lot of changes of late in the industry and an emphasis on making sure to tie reimbursement to clinical outcomes. And so the intent of the risk adjustment model and of capturing and documenting codes, be it Medicare Advantage, Medicaid, or our commercial ACA patients, is that the monies are available to provide the care that we would anticipate that one would have. There's been a lot of discussion around making sure that folks are, for lack of a better word, quote unquote, game the system and maybe apply diagnoses either sooner or ones that are unfounded. But your model is different. And like I shared, I think that adding that clinical aspect is so important because really at the end of the day, we want to make sure that we're connecting the administration portion of risk adjustment and accounting back to clinical and making sure that that's to provide better care, better outcome for patients, experiences for the doctors. Well, maybe you could talk about, and I know it's been a long time, how you've seen that evolve over time and the hope that best you are based on.
That's actually a very good question, Shannon. And in the past several months, what I have seen is the conversation has obviously fundamentally shifted. We're no longer talking about whether a code was captured or did we miss that opportunity or not, right? We're talking about the clinical picture is real and whether that clinical picture is documented and is defensible. That is very important. As many of the governing bodies like CMS or IG and even the commercial payers, they're no longer looking at what was just submitted. They're assessing whether that documentation supports whatever code has been submitted over time and if it is defensible. And that's a very different standard for most organizations. And what I'm finding is most of them are not ready for it, unfortunately. As coding correctly has always been the fundamental rule for many years since the inception of coding guidelines that has been established. And not capturing that clinical acuity and demonstrating what actually happened, what was evaluated, what was assessed, what is documented, the condition, the way that it truly reflects the overall care of that patient with that health status, it puts that organization under a lot of financial scrutiny, compliance, because as I will continuously elaborate, you have to make sure what you're submitting is defensible. And I do feel that many organizations, they forget this notion where oftentimes they're looking to optimize on top of what they're already submitting. And what I always reiterate is let's take a step back. Let's make sure that what you have already submitted is defensible. And then we can build on top of that as you continue on.
Now, we're playing devil's advocate. What about those that would say to you, I use it, and I know we're going to get into a deeper conversation about AI.
Yeah.
But what about those that would say to you, I use coders and or non-clinical folks, and they get the same results. I have a system in place and I make sure that they're getting, pick your acronym, right? MEET. So monitor, evaluate, assess, or treat, or DSP, diagnosis, status, and plan. I make sure that's provided in the record. And so I know it's defensible. Or even now, there's AI tools out there that are able to identify and check the box where the M is on monitor and or evaluate, so on and so forth. Why is a clinician better? What is it about your model that you think that makes it stronger or better than what might out there today that others might be using, whether not using clinical people, they're using other means or mechanisms to get a defensibility?
That's a very fair question. And I've been in this industry for over 25 years, and I hold many of the coding credentials, coding certifications. I'm an SME by training, and I have overseen many large coding CDI groups. In my years of experience, and this is no disrespect for any coders or CDIs out there that do not have that clinical background, by all means, there are no disrespects to that. And I do know there's a large portion of the certified coders, certified CDI reviewers out there that are non-clinician, and that is okay. However, what we have found in our experience is that the clinical understanding, the clinical gap, if it is truly not there, what it does, it frustrates your clinician and it increases this distrust between the clinician and coders. Most often, when I engage in conversations with clinicians, even if they have a team of coders or even an AI tool, they get frustrated because they tell me they can't seem to see what's happened to this patient. They've sent me this query asking me for this information, or I've been pushed back on wanting to document this diagnosis in certain way with these services, but there is a gap of understanding. And that's what we've truly tried to bridge that gap at Chirok. And that's one of the reasons why we have elected to have most of our staff to be clinicians. So that clinical gap, when it is there between coding and clinician, because it is truly fundamentally, there is a gap. There is a gap between coding guidelines versus clinical guidelines, patient care guidelines, and those two don't really speak to each other. So oftentimes as a coder, if I put on my coder hat and speak to a clinician, I guarantee you 100% I will lose the engagement of that clinician. But when you're putting on your clinician hat and talking to that clinician as a peer-to-peer, it changes the whole dynamic of the conversation. And that's really one of the major reasons why we have chosen this path. And we have continuously seen the success in our environment as well.
You bring up so many important points, and there's a bunch of areas that I want to dig into. I'm going to take the first one, though, which I think will be really important to our audience. You talked about what hat you wear and then being able to have a conversation with clinicians about what the appropriate codes are and how to interpret the notes. I'm curious, why is that important? Especially given today's climate with OIG and HHS and CMS.
In terms of it's the importance of having a clinician coder. So that's a very good question. It's a fair question. As I had alluded to in the beginning of our conversation, is whatever that has been transcribed in terms of documentation or dictated, and that documentation gets transcribed into a claim through coding, we want to make sure that is defensible. This is a very important terminology. And who is actually interpreting that transcribed note into that claim, to the codes that get on a claim? And in many years of my experience, one of the things that I have high hopes for, and I would like that to improve, is some of the fundamental training and education that we have laid out for our certified coders or certified reviewers. I do believe that there is a strong need for certified coders and certified CDI reviewers, especially in nowadays, since we are living in the AI era. There's a lot that autonomous coding can do and is sophisticated in terms of translating the node into a codable diagnosis, where those certified coders or certified CDI reviewers have to have a solid understanding of the clinical picture, because it is no longer the basic foundation of coding, where if you take a few hours of training and you go through a certification process and you get credentials, but you really don't have any understanding of certain disease process, or when we're talking about a procedure, how does that surgeon think through that procedure and what are the relevant steps for when a patient presents to the hospital, they have certain signs and symptoms. What are some of the possible diagnoses that could be correlated to those signs and symptoms? And I think that is one of the gaps that I see as a need for current certified coders, certified CDI reviewers, where there might be that understanding, that gap in terms of clinical understanding, especially in the AI era. Because right now I see more and more of CDIs and certified coders to be moved into the validator positions. We are no longer at the upfront position where we review 100% of every node and we have to make sure all supporting evidence is there. Many organizations have implemented AI, and you want to make sure you have a strong team that comes behind the AI and validates that AI. And that validation, the person who becomes that validator, in my opinion, has to have a good understanding of both worlds, the clinical documentation coding as well as the clinical representation, to ensure that it is being reflected. Because from time to time, we see that errors happen and things get to be overcoded or undercoded. So in any ways, we have to make sure that we are minimizing those errors as much as possible.
I think there were several words there that I heard in your answer that were important for me too, because when I think about the larger mission, right, or missive of CMS for the healthcare industry, it's to provide the right care, right time, right place, et cetera, et cetera. And so to get at that larger goal, sometimes we break apart systems. So going back to what you said about story, I think when we pull out pieces of the story, they can become disconnected and you have gaps. And I talk about with others over the year and over my career about minding the gap, how you can have different pieces or components, departments within an organization working on certain parts of, say, the larger story, if you will, or the larger process. But what happens is when you pull pieces out of context, not that it isn't the right way to do it, because sometimes if you take things in whole, you can't have the focus or the depth that you would like or the expertise. But you have to recognize that when you start to put the pieces back together, that there are components that could be missing. And like you said, I can see that while you're looking at particular codes and you're looking for the components that would then defend and substantiate that code, you still have to have an understanding of how that fits into the larger system when we talk about, again, that story of improving healthcare and making healthcare in and of itself more efficacious, if you will, for patients. So it's like I think I'm going to throw out all these analogies here, but the forest for the trees, but you have to see the trees, forest, and then you got to bring back the tree again.
That's right.
In all those different ways.
Yep.
And definitely see that being important for CMS and OIG and HHS. And that's how we should about the work that we're doing.
Absolutely.
Talk a little bit about, because you said clinicians, and that can appear in different ways, right? Talk about the clinicians that you are enlisting for the work that you're doing. And I think the same could be said too, right? That they have to mind the gap as well. Maybe they have a better way of doing it. They have to understand coding, the clinical, and be able to met or go back and forth between that. But talk a little bit about the clinicians that you're using on your team and how they are prepared to do this work and mind the gap.
Yeah, absolutely. And in my years of experience, when we are using this method of stating having coders that are clinician, in my opinion, not every clinician can be a coder, and not every coder you can turn them into a clinician, right? So you have to find this meaningful path for both. In our environment at Chirok, obviously our basic standardization is that a person has to have that clinical background, whether that is a degree as a medical physician, medical doctor, or a pharmacist, or an APP, whether that's physician assistant or a nurse practitioner. And the reason for this is that it gives us a very solid foundation of understanding disease process, clinical representation, clinical picture, what it means when we're looking at certain lab values and or when we're looking at a diagnostic value or when we're reading a clinical note. That clinical picture, if that person can visualize it, then through our internal boot camp, we've developed a boot camp that spans over 6 to 8 months. And because we do believe, while no disrespect for everyone's coding and CDI program out there, but we do have a pride in our program where it's proprietary and it is specifically geared towards what we consider our own solid training program for coding and CDI. So as these clinicians come on board with us, they're onboarded onto our boot camp. And that boot camp, as I mentioned, is over 6 to 8 months. So that means this individual is not able to really work with any institution or medical groups or anyone until he or she passes through certain thresholds that we have put in through this boot camp. And by the time they graduate our boot camp, these are individuals that are solid. They would have good understandings of the clinical picture, but they also have a good understanding of the areas that they would be responsible for. And the way we've designed this boot camp is that while there are some small percentage of us out there where we understand many areas of revenue cycle, whether it's fee-for-service revenue cycle, hospital revenue cycle, meaning DRG, or even on the value-based side. And when I say we, just myself, you, and many others, that is a very small percentage. What we find in the industry to be more useful is that for that individual to become really adverse in one area. And that's also how we have tailored our bootcamp, where we do have certain individuals that have the ability to understand both the fee-for-service and value-based, since those two correlate with each other quite often. And then we have individuals that have a good understanding of the hospital and value-based. And then we also have individuals that just really focus on one area because that's their capacity can only go that much. And we allow them that opportunity and we let them flourish in those areas. And again, with any of these programs, you really have to have a meticulous way of designing and execution. Execution is the most important when it comes to any training program to be successful in ensuring that the outcome is what is being intended for it. Now, an individual will not have 100% passing rate through everything, but over time, he or she starts to excel in many of the areas and the different tools and the mechanisms that are being built for them in ensuring that that consistency of the education and the training is continuously produced for them. And when they're taking it to their own individual work and being assigned to individual health systems organization, they see that consistency, what they've learned in their training program, they see it being carried through actual production work as well.
I love your sharing the various talents and accoutrements among your team. And again, getting back to the critical thinking that's needed to combine all the different aspects of the record that they're reviewing and telling that story of the patient. And you mentioned like hospital and DRG and those types of things. Are you saying that you not only look for substantiating diagnoses for risk adjustment, but can also look at quality measures, recommendations around utilization? In the industry, we talk about concurrent, prospective, retrospective review. Is it billing? Would love for you to talk about the breadth and the depth of your services that you're able to provide or that you're currently providing to clients.
Absolutely. So there are, I would say, three major tiers the way we've designed our services in the organization. And some of these tiers have some hybrid connection between them. So if we look at, let's say, hospital DRG, yes, we do have the capacity of looking at records as a CDI reviewer that would be dedicated to a patient coming in, being admitted, and for that CDI reviewer to be reviewing the documentation concurrently and ensuring that the most accurate DRG, working DRG is being represented all the way to the patient being discharged. And once it gets to coding in the back end and ensuring that appropriate queries and communication to the clinician is being handled on a concurrent basis. Within that, we've implemented a lot of our value-based services as well, because as there are certain diagnoses, not only it helps to accurately capture the most appropriate DRG, but it also helps to capture the most appropriate acuity of that patient. And then we also have our fee-for-service, and fee-for-service looks at everything from procedure coding to M coding, evaluation, and management, both on outpatient side, meaning ambulatory, as well as inpatient hospital, skilled nursing facility, home health, rehab, across the board. And within the fee-for-service model, this can be done on a concurrent basis, which means 100% charts goes through 100% concurrent review, or oftentimes we are what we consider ourselves to be that defender or overlay for many of the encounters that goes through the fee-for-service coding. And my team reviews those charts when they go through AI autonomous coding to ensure that it is truly accurately reflective. Third component of our services is our value-based model. And within the value-based model, we have our traditional concurrent review as well as retro review and pre-visit. Our pre-visit model, it's a little bit different than everyone else's. And this is one of the areas that we pride ourselves, and many of our current customers really appreciate the value that we bring in a pre-visit model is a capturing and reviewing on so many different levels, whether it's on the quality side, it is abstraction, or suspecting diagnosis. Our goal is to have at least 75% to 80% acceptance rates for our suspecting diagnosis, which is very aggressive in the industry, but we've designed it in that matter. And one of the reasons why we use clinician coders and have set up that high threshold is for us to ensure that the diagnoses that have been missed throughout the years for that patient are being suspected accurately, and for that clinician to really understand the clinical picture before at the time care. So there are bundles of different components, different services that have been put into our value-based services where many of our customers leverage. And it's honestly, at the end of the day, Shannon, it is really multiple services where our customers pay for the price of one. And our methodology there is that we've assigned a clinician coder to that encounter. He or she is in that encounter. We want to make sure that the end-to-end of that encounter, whether it's on the quality side, whether it's on suspecting, whether it's on fee-for-service, whatever the matter is, we want to make sure that we are capturing it. So, and this is really one of the reasons the way we've designed our boot camp and our cross-training many of our team members in fee-for-service, value-based, DRG, utilization review, just so that they have this correlation of understanding when we are speaking with multiple needs within an encounter, that individual really has a good understanding what he or she needs to be looking for and what he or she needs to be addressing with a clinician from a documentation gap and what needs to be really captured.
So I think that's fantastic that you have all of that together. And then again, that folks have that wealth, that depth and breadth of knowledge so as to mind the gap. And I think that you can't really put a price on having things accurate, but I can see the CFOs in our audience, especially in an industry that has tight budgets of late, saying, that sounds expensive. What would you How do you work with clients of varying budgets and different aspects of scale?
Yeah. Being in the industry for so many years, it has led me to understand the cost around. Because I've been a vendor at some point I was a client at some point in my life. I've worked with global companies. I've worked with only onshore. Having this solid understanding and I've been in that situation where I was given a very tight budget, but I needed to make something really big happen. And being that VP of risk adjustment or VP of CDI or VP of coding or even at that CFO level, thinking, how am I going to do this? This is some of the thought process we have put in place in designing our program. But how does that really translate to a cost to our customer? One of the approaches we always take with our customer is that I always ask them, what is your budget? What are you working with? Let's start from there. Because what I truly believe as an individual is not so much for us to make a dime out of a customer. We are a very relational company. The partnership and the trust that I built with every single of our customer and my team that builds it with every single customer resembles the work that we do and the continuation of services we provide to them. That partnership and that trust for them means every penny to me in the world. And at the end of the day, I always start out with them to tell me, here's what I work with in terms of my budget. And I try to give them the maximum of everything in terms of our services, not even pinching and diming to say, well, because your budget, I cannot give you this or that. Because I truly believe when I give them that and the customer sees the return, and we do guarantee the return of least within the first 3 months. If that customer does not see that return in the first 3 months, we will be the individual at the table telling the customer we need to do something different because we don't want to take your money if we can't give you something in return. So we guarantee them of the return compliantly, but we also want to make sure that the customer's demand has been met. Oftentimes, many of our customers, if you talk to any of them, they will tell you that Chirok goes way outside of everything we have designated in our contract. And there's a reason for that. Again, because at the end of the day, it's the relationship that matters to us and not so much we have to follow these 1, 2, 3 steps and we cannot do 5 and 6 because it is not in our contract. That's just not how you build a relationship and that's not how you build trust. We take a pride when that customer comes to us and wants to really learn from us and asks us what is the latest updates and guidelines, guidance, right? They make us part of their decision-making process. I don't think you can really put a price on that. And we're not a company that's based on transaction, really. So
Those folks wait for on a line back. And then I wanted to also bring in a little bit of what we talked about earlier about clinicians being able to traverse that gap. I was hoping maybe you could provide us some stories from the field, not giving client names away or any proprietary information, obviously, but maybe an example where using a clinician, something specific, like a condition or a project or something that you worked on, where you were able to demonstrate the value of using a clinician in those roles, and then how that then demonstrated that ROI that you had shared.
yeah, absolutely. We actually have many examples that I can provide right now, but what I can provide to you are two simple examples. One of them was on our value-based services. And this was a customer that had implemented an AI technology. And the AI technology it's doing what it's designed to do, right? Looks at the documentation, suspect's condition as it should, and surfaces a diagnosis that has not been reported. But as you and I know, with many AI technologies, you really have to have a good understanding of certain diagnoses that are being surfaced. And in this situation, there were a quite handful of diagnoses where the AI technology continuously suspected based on certain medications. It was looking at the dosages, the duration, and the type of medication. And this was for one of the mental health conditions. And this is one of those examples that if we didn't have our clinician CDI reviewer there who would question all these suspected diagnoses and flag those for the AI to push back and say not a valid suspect, it's not really visible why this patient was prescribed this medication, or we need to have more evidence before it's being suspected. And there was a good hunk of those diagnoses where it was brought in front of the CMO and the medical director, and both looked at it, validated, and agreed with our clinician CDI reviewer, and really appreciated that she's the gatekeeper in making sure that those diagnoses really never made in front of the clinician point of care, because it will trigger this notion of distrust with the clinician as well, where based on poor evidence to be suspecting such high value diagnosis. So that's one on our value-based side. And on our fee-for-service side, one of our customers had a very low rating of transitional care management routine. And when we first engaged with this customer, their TCM services was around 85%. And they really didn't have a good understanding of what was really happening. They had some, but you really needed someone to follow that patient from the time they're being discharged all the way to when they're coming to see the clinician. And even after that, what is happening to the path of that patient? Where's the gap? Where's the communication not happening? Was there the clinical outreach? Did the clinician not bring in the patient on time? Is the documentation not supported? So there were multiple steps that our team took, and we put a full project plan together, and we did put a goal. That was the very first thing we did. We said, we want to increase this reporting. The customer was going to be very happy if we can increase this by additional 25, 30%, because it was actually, they were being incentivized in their TCM reporting as well, part of their quality reporting. And they were like one of the lowest reporting across their peers. And this was like about a 3-month project that we dedicated, but the 3-month project obviously became a continuous, but three months of just really intense validation and review. And I can proudly say that we brought that TCM reporting at 35% to 93%.
Wow.
And
Wow.
it is one of those moments for every single leader in that organization who are sending us individualized thank you just because of a lot of the work. But at the end of the day, we take pride in that. It is success stories like that helps us to do a lot better and more for our customers, and ensuring that the care of the patient is the most important, is being delivered, right? That enhancing the quality, we take a huge pride in that, because we feel like we're side by side the clinician as well, and helping them improve the quality of that patient care. But then also improving the quality reporting on our customer side as well. We also take a pride in.
Excellent. Kanar, I know we've been talking about how we can best capture care and being able to tell a patient's story, but we still see across the industry, there's a lot of screenings, ones that are important that we know are prevalent conditions out there in our communities that are not being done. And I'm thinking about those things that maybe have stigmas around them, like depression screenings or substance use disorder screenings, dementia
Yeah.
screening.
Yeah.
Why do you think that those screenings are still being done, even though we know that they're highly prevalent?
Yeah, no, this is a really good question. It's actually very important because as with COVID, the rating of depression and substance use disorder has increased over 40% and 60%. So I think it is both knowledge and workflow problem. And if I have to weight it in, it is more of a work. So the thing is, Shannon, is that most clinicians know that they should screen. The tool exists for most of them. The issue is that what we are finding is that no one has really built the operational infrastructure to ensure that it happens reliably, that it gets documented properly, and that the result, there's action being taken. I kid you not, so many times I speak with clinicians and they say the patient filled out that form and the form is left in the room and gets discarded. It's unfortunate. And that data gets missed. You really never know what's happened to that patient, where there's screenings, their depression screening, was they positive, negative? Did we need to take some actions, right? So it's really, truly is the workflow that we find that to be an issue. And through our concurrent coding program, that is one of the gatekeepers that we have put in place, especially for many primary care, family medicine, pediatric clinicians, where we have a way of reminding the clinician, looks like a depression screening was intended to happen, or certain developmental screening was intended to happen. Did it happen? And if it did, where are the results? Sometimes they don't have the bandwidth. They don't have the clinical staff. They have the pile of papers in a box and it just sits there. And a week, 2 weeks has gone by and nobody has time to enter the results into the EHR and see what the outcome would be. So it's really just the workflow that we find it to be an issue. That infrastructure that's just not designed to help bridge a lot of those gaps as well.
One, I hate to think that form that I hate filling out. It doesn't-
Just stays there.
I know, I understand. What are ways in which you are helping them cure that gap? It improves the workflow intake and delivery,
Yeah.
so that information is used. Are there things that you can do to help support with your team?
One is that we want to make sure that we help many of our customers understand, first of all, when is the appropriate time for these screeners to be administered, right? Is it at a time where it's an annual visit or at a physical, or if a patient is coming in regarding those matters? Because you don't necessarily want to put in a workflow where a patient is coming in for an acute illness, and then you prompt the clinician to administer a screening while the patient does not resemble any sign and symptoms of, let's say, depressed folks, right? So that's the first key, is to working with them, ensuring to have a good understanding of the various types of screening and at what point of care these screeners are to be administered. Once that has been established between us and our customers, then we design a workflow in ensuring that we remind the clinicians to let them know this patient came in for annual wellness visit, right? Part of annual wellness visit in the initial depression screening, some type of a mood screening has to be administered. It's a requirement. If that is missing, we ask them, this is part of their free benefit to the patient. And did you administer this? And if there is, where are the results? So what it does, creates awareness, Shannon. They may not give us the answer. They may tell us for that specific patient, oh my goodness, it was a form, they filled it out, they left it on the chair, and now it's gone. It's been discarded. But what it does, it creates an awareness for the next patient. And that is our goal, is to create that awareness, that education, that transparency, where from time to time, and we actually track this on our side, for any given clinician, when they get onboarded on our services and our concurrent coding service, we track to see what the capture rating of any of these screenings from the baseline and month on month as they're continuing with us, what does that look like and how we can increase. And we provide them a lot of feedback on the gaps and the areas of opportunity.
If you were advising a mid-sized primary group tomorrow as to 3 areas or workflows that you recommend they fix today, what would they be?
One would be definitely on the screeners, right? The types of screeners that would be most applicable to their specialty. Definitely PHQ screening, definitely something like a MOCA screening, as well as alcohol or substance use screening, just because, as I mentioned, unfortunately, after COVID, we've just seen an increase reporting these various conditions. And as on cognitive impairment, there is a huge underreporting. Many patients are being misdiagnosed, and these would be some of the screeners and the workflow that I would recommend and work with any mid-size primary care group in ensuring that these workflows are put in place. Because through some of those screeners I mentioned, it's not just about the screeners and the form, right? There are just so many different things that gets to be monitored, especially from a patient care aspect, all the way to quality care and metrics that is very important in enhancing the overall quality of that patient.
I'm glad that you brought up those specifically too, because as you said, we saw an increase, right? And those conditions during COVID. And a lot of folks would say, oh, COVID's over with. That was way last a few years. And the thing is that the remnants, the impact of it still exists, and that we're still seeing that increase in those conditions. Kanar, for a lot of folks, I know that we've touched upon AI and the importance of it and the benefits of being able to elevate coding teams to be validators and in all the ways that it can make the work that we do more expedient. But there may be some challenges too. And I think that we're learning, right, that there are questions that we should ask, that we should be discerning buyers. Given your wealth of experience just in healthcare in general, but then also with these tools, are there any recommendations that you would make to teams, to executives, to others that are considering the use of AI tools, whether they're using them for the first time or they're evaluating existing vendors and tools that they're using? What are some, what's some advice that you might give them in considering these tools?
Yeah, absolutely. It is actually a very important question. And thank you for proposing that, because in my mind, it's going to be really simple. It's really 3 questions that I encourage everyone to ask. Even in your day work that you work with AI, and then specifically in healthcare that many individuals are leveraging AI. One is, what is the validated accuracy on the patient population? Not just some general benchmark, right? So that AI vendor should be able to provide them. I would ask them, who is going to be responsible for the errors? And that third point, which is going to be very important, is what is the human review protocol? If the vendor cannot answer then these questions, or that vendor's able to produce these nuances, then I would take that as the answer. Because in my mind, Shannon, AI is trained on patterns, right? And patterns in healthcare data, they're often wrong. So if the training data reflects underdiagnosis, for sure the AI will underdiagnose. If the training data is reflective of a bunch of upcoding, the AI will definitely upcode. So this is why that third point of what is the human review, that validated protocol is going to be really important. And we all know that many of the AI technology companies don't have that servicing components, AI, the human reviewers. And oftentimes, as an individual, you may not want to have someone as that, someone within the AI company to be that validator, right? Because there might be this notion of some of the information not being transparent at the front end. My recommendation is to have an unbiased third party to be the validator in the midst of both the AI and the healthcare organization. That is the best representation of what I have seen worked. And not only what it does, it enhances the accuracy of the AI, but it also enhances the accuracy of what is being reported on the customer side. The health organization is also happy in terms of some of the outcomes and the output, and they don't have to put their own resources to be that validator. So I think this mixture of this trio dynamic will help alleviate some of the pain points we're seeing and what's going on right now, really.
That's great advice. Kanar, we started our conversation talking about the importance of defensibility around coding. There's been a lot of changes for 2027 around not allowing unlinked encounters. There's been a lot of changes and making sure that plans are not overcoding so that they're getting, as you said, that story, that patient story right. What recommendations would you have for leaders out there on how they might be proactive in preparing their organizations for the changes that we know we'll see?
I'm going to go back to probably my favorite word, and that is documentation defensibility. The rule signals that obviously CMS is moving forward to requiring that the diagnosis to be clinically validated, not just about documentation anymore. So for most organizations, they need to make sure that there is a need of audit of their documentation practices against the standard. And this kind of goes back to oftentimes many organizations, they look at their overall risk score and they say, oh, our risk score is low or high or whatever it might be. And my thing is that if your risk scores are, if they're inaccurate because your documentation is incomplete, then of course your MLRs will always look worse than they should. You're taking on a risk that you're not being compensated for. Therefore, accurate documentation is not just a compliance issue anymore. It's a financial management issue. And to be honest with you, Shannon, in my opinion, many of those organizations that are not proactively looking at their current infrastructure and ensuring that documentation defensibility is there, there will be some that they're going to find it hard to survive in the next few years. And those organizations would be the ones that have treated documentation integrity as more of an administrative role rather than a clinical function. And also those organizations that have outsourced all their coding or clinical documentation to an AI company without any governance or an oversight on top of that. That's, in my opinion, those will be the ones. They may not feel the struggle today, but they will definitely start to see that struggle in the next coming years, sooner coming years rather than 5-10 years from now.
I like how you brought our conversation full circle, and it's something I know we've both been in the industry for a small amount of time, and we've talked about this. It used to be everyone focused on risk, and then it was quality, and both of them, seem to have footing. But now we also talk about cost performance and care management and the importance of managing utilization and appropriate care. And really, when we're thinking about value-based care, you really have to mind all those segments of your business if you want to be successful. And I definitely think you elevated how we think about documentation, that it's not necessarily this administrative function, but can really be used for the clinical good in those better outcomes. We've talked a lot, and I know we could talk so much more. I'd like to give you an opportunity before we close out today. We can always have you back as a guest, but anything that we didn't get to today that you would like to leave as parting advice with the audience that you think is important that they pay attention to, especially working ahead the next 6 to 12 months in the industry, that you think folks should really attend to in order to perform?
I think, again, thank you for having me as part of your podcast. I truly enjoyed this conversation. And as you said, we could be talking for hours because we obviously have so much in common. And the one thing that I would say as a parting advice to many of your listeners is really choose the right partner for yourself that will go hand in hand with you and ensure that they are your true partner in every step of the way. Whether they're your revenue cycle partner, your AI partner, your coding CDI partner, choose someone that you know you can 100% rely on and that they will take you through every step of the way and ensure that the current revenue is defensible and then layer everything else on top of it. That's going to be really my main message, because that transparency and that trust is really continues to thrive at the end of the day.
It's hard, complicated work, and relationships matter. You need to make sure that, that folks have your back. Well, it has been my pleasure, and agree, we have to have you back again so that we can continue to discuss further. Kanar, thank you so much for giving your time and sharing your story and the good work that you're doing at Chirok. And thank you again. Thanks for being with us.
My pleasure, Shannon. Thank you. I appreciate you.